welcome. We'll get started. It's 10:06. Welcome to the May 23rd Finance Planning Agenda. I'm informed of no citizens wishing to address the committee, so we'll move to approval of the minutes, item 3A, and we'll need a motion for that or any questions. I guess we have a quorum, don't we?
We do.
Okay. Daphne's making sure. Okay, we have a motion and a second. Second. Any question or discussion? If not, all in favor say aye. All opposed, same sign. That motion carries. Thank you. Okie dokie. Let's move on. Jill, reports, master facility plan, construction project update. We have updated the placemat, if you will. I think it's much more user friendly and useful now. So Rory and Jill, both thank you for your efforts on that, but we'll let them walk through that with us.
Yeah, we'll continue to refine them as well, make them more standardized. We have different project managers that work on these various placemats, so we're continuing to refine that. I have David Watkins here from Brada, so he'll provide us an update today on Medical Home Southwest and the Psychiatric Emergency Center.
Welcome, David.
Thank you. Progressing good towards that. Right now, just a quick overview on what's going on the job site. You know, the mechanical, electrical, plumbing installation, both overhead and in walls going on. The rooftop units have been set. You know, exterior wall, close up, roof, all that stuff's going good. The things that you may not see is procurement of equipment, furniture, and signage has begun. That's important to get to that end date, so everything's moving where it should be. And I guess the other exciting thing is we're getting to do a few walkthroughs on the site. So, you know, we're starting to close up walls now. People can see their spaces, see how it's going to operate and function.
Dr. Duncan and I had the opportunity to go visit the site a couple of weeks ago, and it is starting to look like a clinic now. You can actually tell where nurses' stations are going to be, where exam rooms are going to be, pharmacy, and all the other associated, you know, KPUs or services. And so very exciting to see it really come together and look like a clinic.
Yeah, I already put my nameplate on the room. So, but did you see? Well, asked about the lots on each side of the medical home. I mean, how bad it is. I don't know if we can talk to the city or court enforcement to cut it.
Our property.
Right. I know it's not part of us, but I'm just, you know, you almost can't see the medical home unless you look above how high that grass is on both sides. Yeah.
And we can reach out to the city again about that.
Yeah.
We politely asked the general if he could take maybe one extra swipe. We can't mow their entire lot for them, but maybe we can make it look a little nicer around ours.
You gotta love codes departments. You gotta love it. All righty. Do they have anything else on the Medical Home Southwest? Any questions? All right, let's move on to the next one.
All right, on the PEC, I mean, we're still tracking for the summer of 2025, looking at July. You know, this month we got the TSP lobby turned over. We got Lot D parking turned over ahead of schedule to help with some of the parking issues. Wished it was more parking, but we're working through that. The exciting thing that's going on that people aren't seeing is all the invites for the exterior wall mock-ups to talk about stone and brick and glazing and waterproofing and air barriers, all that kind of stuff that's going on. So that's what's next on the list after all the steel's up, is exterior walls going. Roof will be going. Shop drawing process, submittal process is probably about 90% complete. So we're geared up to start, you know, the meat of the construction next phase. Next steps, it'll kind of follow medical home. You'll start seeing the in wall on mechanical, electrical, and plumbing systems and overhead as we move forward.
Any questions on PEC? All righty.
No, I didn't ask for a room over there.
Well, they already have one with my name on it. All right. David, does that do it for you? Anything else?
We're good, sir.
Good to see you. Thanks for being here today. We appreciate it very much. All righty, Rory.
Or item, please, Chair, if possible. I'd like to call up Ramon Gajardo.
There you go, sir.
Oh, that's.
Not me, but I'm junior.
I want to introduce Ramon Gajardo. He is the president of Raymond Company and has extensive experience working for clients with program and project management. He's also a resident of Tarrant County. I'm excited to say we've engaged Ramon over the next few months to work alongside our JPS staff. He's going to be reviewing key components of our program, overall management, budget, schedule, stakeholder engagement, as well as procurement processes. And so we're excited to have him on board. He, previous to working at Raymond, his company, also worked for Burns, so heavy construction experience as far as project and program management. Clients have included American Airlines and HCA, THR, USMD, Texas Wesleyan, many of the key players around Tarrant County and further. So want to introduce Ramon. You may see him coming up to make some presentations in the future. So welcome, Ramon.
I do appreciate it. Thank you all for this opportunity.
Welcome, Ramon. It's and Jill and Karen and I had a chance to visit with this in advance. I think this is a great move for us. With the transitional changes we've made in personnel, making certain that we've got extension of hospital staff kind of watching things for us and reporting back to us, I think is a great idea. Ramon's got a fantastic reputation. His company has done work even larger than ours. And so, Ramon, welcome. We appreciate it. Please make it a habit of coming back and visiting with us.
Will do. Will do.
So we can visit with you. We probably won't subject you to the entire board, but I think this committee is going to be very interested in hearing your reports.
Absolutely.
So we appreciate very much you being here.
Thank you for the opportunity. I'm looking forward to it.
Formal action on that, do we?
No, we don't.
Okay. That's within the administrative authority of the CEO, so we don't have to take action. So fantastic.
Thank you.
Glad to have you here. All right. Rory? Welcome, sir.
Good morning. Good morning. My colleague Colin asked me if we were going to be here the full 2 hours. I'll do my part to not make that happen, Colin.
2 hours?
He asked if it was going to go the full 2 hours.
The last hour of the meeting.
A couple of things, just general CFO report. Hilltop Securities, we do a quarterly investment report. That is posted in your portal. You should see that now. Just some light reading there for you if you would like to partake in that. If you recall, in March, we received information that our federal DISH funding that was slated to be cut had been, extended, so there will not be a cut in this year. We still do not have a number yet on that. We expect a number around June, so we'll keep you informed on that progression, but the cuts were delayed, and I expect that to come up again in the December legislation around budget talks at the federal level. So for this year, we are good for DISH funding, but we do not know the actual number yet.
So Michael's right. He was here the other day.
He was. He had a crystal ball.
Well, I think he does have a crystal ball. He has his thumb on the pulse up there. So good news. Roy, just to take you back for a second on the investment report, and that's in everybody's backup, so I hope they have a chance to look at it. We get those quarterly.
Yes.
So we typically don't make a habit of bringing the group forward to talk about those unless there's questions, but it's crucial for us, right? And the interest rates are changing. So, Rory, I think, just let's have them come at some point during the year. Not so much as to question the portfolio, but to try to give us some idea of what we're looking at.
Yeah, they usually come once a year.
Yeah. 'Cause we typically do it in the fall or late summer.
It's usually later in the year.
Okay.
But
the end of the year.
I think we had a little delay this year getting just scheduling this year.
Okay.
The highlight in this month's report is just the bond market is being affected by interest rates rising. So we have some paper losses in the bond market. We had to book, but those are of course going to fluctuate. So
Yeah. Well, we've got a lot of outstanding unspent bond money, obviously, and going to have a lot more So let's just be sure toward the end of the year, they come in and give us a chance to visit with them and hear their forecast on where that's headed. So sorry to interrupt you. Go right
Oh, no,
ahead.
you're fine. At the state level, we continue to follow our CHIRP reimbursement funding. CHIRP stands for Comprehensive Hospital Increase in Reimbursement. It's a premium to our Medicaid rates that it helps offset the cost of care for Medicaid. We don't get paid anywhere close to our cost through our normal fee-for-service reimbursement. So this is a supplemental program. In years prior, it has been just pure claim-based. So we file a claim and we get the additional premium. This year, in fiscal year 25, we will be moving to a quality-based component. About 42% of our total funding will shift to a quality-based component. About 6 measures, things like cesarean birth rates, post-op sepsis, planned all-cause readmissions. So we feel like we'll do very well with those measures, but it is a shift in the way that we are funded.
Yeah, no, and we will bring that to the quality. Those will be metrics that the board will see, since there are financial implications for those metrics. But Rory, about how many? It's quite a big bucket of money.
It is. It's probably somewhere in total around 15 to 20 million will be subject to that quality measure.
Dustin, you're really going to enjoy your time on the board, because what you're going to see is the federal government will give us all of these opportunities to brag and show our amazing quality metrics. We had a program called DISRIP where we laid out all of these incredible partnerships and all these things we were going to do in the future and all the quality measures. And then about 2 and 3 years into it, they said, oh, never mind. Not that important. Here we go. We got another one now that's going to actually theoretically, rely on quality. And the good news is our quality stays, whether they give us any, regard whatsoever for it. But you'll enjoy watching that roller coaster. It's quite fun. Editorial comment.
No, that's great. So I like to keep you updated on all things supplemental programs because it is a moving target. In this month alone, we had a program at the state level that was on, off, and back on. And so trying to figure out and predict what that funding is going to be, especially at the state level, has been very interesting over the last couple of months. So in your financial packet, we'll kind of, you have the narrative there. I don't spend a lot of time on the narrative. I do want to pause this month and give a little bit of explanation on the next slide. This slide is not in your packet. It is on the screen. But this is something we've been kind of piloting with the chairman and vice chairman of the Finance Committee, just to give you guys a real high-level summary. In case you do not have the opportunity every month to just do a deep dive into the packet, we're going to try to bring forth a summary that would allow you to see our statistics, our payer mix, our income statement, and then our balance sheet. So this is something we'll try to bring to you more timely next month. But I think it's good just to be able to see a very, very high-level look. Couple things I would highlight in the statistics this month. We have a variance to budget, but we also have a variance to the prior year. So it helps you see not only where are we at now, but where are we looking in comparison to the prior year. So almost green all the way up and down to the prior year. And then we have, of course, a few areas where we're not quite on target. But the payer mix section is well documented what's going on there. We have lower Medicaid due to unwinding and also a little bit better Cigna marketplace improvement in commercial. The rest of it is kind of what I would call normal shifts from self-pay to connections and then just a very small increase in Medicare. And then we have your days cash outlined in the bottom right, as well as the total operating cash dollars. I did look at this month a little bit. Why are we lower in cash, 25 million from the prior year? We've got some debt service dollars that are allocated for paying bond cost, and so that's the real decrease in cash. We've actually grown days cash on hand a little bit over the prior year, 11 days. And then the bottom left is your income statement. Really just can kind of see where we're at from a net patient revenue, also supplemental expenses, operating income, and net income. So questions or comments, this will be your summary page going forward that we'll use.
Rory brought this to DT and I last week as we started talking about what these dashboard, snapshots need to look like. And so what we'd like for you all to do is, begin considering not only these metrics, but others that you think might be useful. Because the idea here is let's give an entire month of snapshot. Let's cover the issues that are important. Let's color code it for quick viewing. If it's a green, it's good news. If it's yellow, it's yeah. And if it's red, it means we're behind. And we talked about this. Using this same sort of color coding for all of our metrics is useful. And I think Rory's done a great job of identifying clearly the key indicators that we're all going to be looking at from a financial perspective, but also indicators that will be impactful on budget, days cash on hand, the dollars that we have available for, future payment for bond debt service, but also dollars that we're protecting for the bond program moving forward. And last year, as you all know, we didn't have a clear snapshot that was an easy picture that we could present to Commissioners Court. Or frankly, I think there was a lot of questions even at the board level about what our finance quality metrics were. This is an effort to really create a visual, snapshot of the important quality metrics at JPS. So as you consider this, this is a fluid, dynamic document. I mean, we want your feedback on it. We want to get input on it. I think it's a great start, Rory. I think you've done a super job with it. But this will be something you start seeing regularly. And hopefully to the extent that there are global questions about finance, they're going to pop up right here. So there's going to be a consolidated place to refer to start looking for answers there. So any questions on the format? I know you haven't got it in your packet yet. It will be there next month. But it's a useful tool, Rory. I appreciate you putting that together for us.
Yep.
So if yellow, does it go to red or you go to green?
So
I'm
anything
confused between that and orange.
Yeah, so anything under 3% is red, anything over 3% is green. So the area in between plus or minus 3 is just kind of gradient or graded. So it's kind of in between. So that's why you get a variation of yellow and orange kind of in there.
But if it's yellow, chances are it's going to go to green. If it's orange, it go to red.
Yeah, that's you're pretty much spot on.
And one of the things we talked about is that it's a little bit like golf, because your negatives in some cases are good news, right? Not bad news. So we want to be able to coordinate the color coding with good news, bad news, not necessarily plus or minus. That makes sense. So that's one of the things we're going to make sure that we do is that you may see a negative number, but that might be good news, and we want to be sure that's a green number.
So length of stay is a great example. It is down 11% to budget, down 16 from the prior year. It's green. So that's a great example of length of stay being a positive movement in the lower length of stay.
And we don't have to deal with colorblind anymore, right?
Well, Robert Early's not here.
Yeah. I didn't think about that, but that could be problematic.
Well, just look at our elevator colors. I mean, clear.
Yeah, we should screen all future candidates for color blindness. Okay.
You have to.
See, they have to
Have to be able to see
yeah,
colors.
because you got to be able to see those colors, right?
We do it as part of
All right, so I'll go to this next view that is in your packet. This is just a more detailed spread of the statistics over a 13-month period. The one thing that I would point out in the month of April is this is the first month of the fiscal year that we have not had any red indicators. So surgery has rebounded, particularly in the inpatient area. We are not green, but we are certainly within that, say, 3% target. And then, of course, PEC visits also kind of took a little nice rebound in the month. But DT, at your request, we added the prior year, April of 23, so we could look down and see kind of how the prior year looked as well. So very positive numbers in April from a statistics standpoint.
The report, everything looks to have recovered that was kind of slow earlier in the year.
It has. We'll kind of see how things play out the rest of the year, but so far things are kind of looking that direction. These are still in your packet. Just they will become, I think, redundant at some point. I think we'll leave them there for now, but that just allows you to see more graphically some of these statistics. The summary gives you more of the raw number, but these give you if you're a graphical person, these are going to be great for you going forward. But we won't spend a tremendous amount of time probably going forward looking at each one of these individually. So
Statistics summary sheet is great for that. The statistics summary sheet follows that same color coding format, and that's going to give us, I think, a better snapshot of this than trying to, slog through each graphic.
Really is good on the summary one because it's so hard to figure it out on the little small one.
Oh, so you like the pair mix on this right here?
Yeah.
Okay.
Yeah, it's easy to see.
Yeah, the other one does have very small numbers. I agree. So, all right. So on the financial metrics, I would point out just one of the things we watch really, really closely is the cash collections. We really were right at target for cash collections for the month of April. We've only had really 1 month that dipped below that target in January, and you can see in February we did rebound. So we're running right at 100% year to date, which is an indicator of are we collecting the revenue that we are putting on the income statement, the net revenue. And then the connections enrollment does continue to grow a little bit there with our expansion of eligibility beyond that first year period. We are simplifying that re-enrollment process for those members.
Rory, on the financial metrics that you show, and I don't think it's necessarily useful or relevant each time, but periodically, would you incorporate an aging report into this so that we can have some idea of how we're doing on AR relative to aging?
Yeah, absolutely.
We're making huge improvements on that and have continued to, and again, those of you, Ralph and I remember, 12 years ago, it was pretty astounding how our aging report looked. It was so far behind. And we've really gone a long ways in improving that. So it might be useful just to incorporate that.
We've, I think when I started here, we were in the low 50s, and we're hovering around 45 right now. We have been as low as 42. So yeah, we can bring that back.
We're never going to be as good as many just because of the nature of our work and the nature of our payers. But to the extent that we can continue to show efforts to improve that, obviously it helps the cash position and shows our the great work of our staff. So just periodically throw an aging report in.
Do we ask the right question here? From the patient cash collections perspective, are we over booking the allowable charge? I just want to make sure that we're booking it correctly.
Say that again, DT, are we over what?
Just want to make sure that we're not overbooking the allowable charge, and then the collection is always higher from that perspective.
Cash collections, really, you have to look at over a longer period. 12 months is really your best indicator. So those things that if we have to misvalue an account or overvalue it, I think is what you're referring to. It does wash out over time. But we value the accounts within Epic, of course, for what the collectability is. And then we also run the entire AR through a historical look-back model each month and come up with the value for collectability. So that's a monthly process that tries to, it is an estimate, right? And so that's part of what Forvis does each year. That's one of our single biggest financial assets is our accounts receivable. They take a really hard look at that to see if it's valued correctly on an annual basis.
Are they looking at also cover the Medicaid eligibility also for the WIP stuff?
They do. They look at the Medicaid pending category as well as everything related to that.
With the working in progress and all that stuff?
Yeah, how much is, so we have a Medicaid pending category, and we know some of those are going to go get Medicaid, and then some of them will not. So we have a split there, and then we value that at the appropriate rate.
Rory, briefly describe how cash collections as a percent of net patient revenue can be over 100%.
You would, in theory, you would be over reserving against what your AR is at. So you have a gross AR and you're taking it down to net. And if you're undervaluing your net, you would collect more over time.
Okay.
But that's the reason we try to stay as close to that 100% mark. That indicates that our financials are accurate and the AR on the balance sheet is accurately valued, but we're also collecting what we say we should be. So that's the test.
Our stretch goal there is 102%. Is that attainable?
It has been in years past, and the reason it has been is we've been a little bit over-reserved probably, but the auditors have done a good job of squeezing that to a more accurate number. So it's pretty close. I would tend to not really worry if I'm at 101, 102,
right,
if I'm at 98. But if I fall below that 98 mark or I get too high, there's something going on there.
Something should show up. Okay.
Are they factoring also some of the value-based contract for bonuses or share savings and all that stuff in their?
So that would be really what I would call outside of the AR, and it's kind of in a separate bucket. Yeah. The DT is referring to some of the contracts we have for value-based care and performance-based. Those would not be in that collection number. Okay. This is the dashboard that we presented last month. I will let you kind of look at that. The only thing I would say is the Fit for Growth number is going to be, I'm going to have to bring that to you probably less frequent than monthly. It's a tracking exercise that we're trying to automate to a little bit quicker turnaround, but it takes us almost a full 2 weeks past the close of the month to get a good Fit for Growth number for you and that cost savings. So we'll probably be a little bit delayed on that metric, maybe 1 month. So I just wanted to point that out.
So briefly, just describe Fit for Growth because we have new folks.
Sure. So during the master facility planning phase, we took a look at if we built certain facilities, a number of those were the psychiatric emergency center, the new towers, the new medical home, and the new surgery center. Could we operationally support it and fund it? So if we are adding infrastructure, then we have to have people in the places that would provide the services, because logically we would need to support that operationally. There's not only just people, but there is the additional depreciation expense on the property, plant, and equipment. So could we fund it? And when I say fund it, would we operationally have enough dollars to support it? So we looked at it over a 5 to 10 year period, and what we learned was we would need to trim somewhere in present value dollars was at the time was about $96 million. Future value over 5 years is more like $133 million. So what we did was go about an exercise of looking for operational efficiency and savings in costs. It included not only cost savings, but additional revenue opportunities. And so this Fit for Growth measure is, how are we tracking towards that 96 million? And so each year, there's a breakdown of kind of what we need to do to progress to that 96. So last year, achievement was 17, and the target was 14. So each year, we have a new target. This year, you can see, is 34. So we were trending just a little bit above that 34 in the second year in total. So that's kind of an explanation on Fit for Growth.
This is crucially important for us. And Dustin, you're new, so I'm giving you the benefit of the doubt on some of this and want you to ask questions. But one of the things that we have been challenged with is, the presumption that because JPS has a significant surplus, that those dollars are unencumbered.
Sure.
They're not unencumbered.
Yep.
They're totally encumbered. But we didn't do a great job of illustrating the encumbrance. So as we looked at the bond program, the quintessential question wasn't, are we going to have the money to build the buildings? It was, are we going to have the money to staff the buildings to the level that we need to based on our quality expectations? So Fit for Growth became, a sort of a hospital-wide, a network-wide effort to be able to say, let's illustrate our financials in a way that don't, create a target number out there that says, here's all of this extra money JPS isn't using, let's just cut the tax rate, right? Well, that, on its face, that might be a conclusion that's a logical conclusion. But when you look at the Fit for Growth metric and you look at the dollars that we are intentionally putting to the side, it's because we've got to be able to meet this metric. And one of the things that the board has always been concerned about is we get these buildings built and we haven't put enough dollars away to operate them in a way that we need to, which would be, devastating, obviously. So we've constantly been looking for metrics that help us illustrate our financial picture, especially to Commissioners Court, but also to the public, that says, look, this is not about JPS throwing money in a savings account that they're not using. This is about illustrating what those obligations are going to look like for the next several years relative to our demand. And it doesn't even take into account potential growth in demand within those services. It's a reasonably static circumstance that just says, based on these buildings and based on what we need to be able to do operationally, these are the dollars that we're going to need. And what it does is you quickly reach the conclusion that continuing to reduce the tax rate relative to that need is going to have a dramatically detrimental effect on our ability to make sure that we staff those buildings. So that has been a goal of the Finance Committee and of the overall board for the last year, is to prepare the budget this year in a way that really tells the entire story. So everybody sees where JPS is relative to that need. And that's what Fit for Growth is all about.
Makes sense.
Yeah. Saying that we're not going to raise the tax rate. We're going to do it at the present tax rate. But if we keep reducing, then how will we be fit to staff and fund what we said to the voters we were going to give them? And so that's a big concern I have, is as we submit that and we go to Commissioner's Court and you continue to say reduce, well, how are we going to reduce and then we're going to still provide?
Yeah.
And that's not fair to the citizens of this county.
Yeah. Well, this metric is designed to make sure that we can illustrate that clearly throughout the budget process, DT.
I think the one thing that happens is probably not needed yet, but as we continue to build the construction, we're going to have interrupted service and all that stuff, patient admission, all that stuff. Should we be looking at the third next available appointment as an indication for access?
We always keep that metric, obviously. It's not one that we have now incorporated back into the presentation, but it's always available.
We follow that internally.
We can always show that. Based on third next.
Maybe
The demand is much higher than actually our supply. Now, we're looking at true capacity from a physical standpoint, before we start talking about additional new facilities. But I would predict that at the rate of which Tarrant County is growing, that we will never be able to meet that true demand
But should we
that is
show-
out there in the current way of which we're providing care. So we'll have to move more to technology and other ways of how individuals can access care. But if you look at it purely from how patients currently access care with calling, getting that appointment and such, our third next available varies a little bit based upon our provider FTE, but we do follow that.
But should we display that so they know that it's increasing? Because otherwise, it's almost like,
I don't know that it is increasing, but I do think we can show it.
I think DT, what I've heard from you is there's this service interruption that could occur with, a good example is we're moving South Campus to Medical Home Southwest. So we want to be able to at least have the patients taken care of and not have a service interruption. And you would like to have a few metrics around how do we know that that's happening? But then also, are we growing?
longer to get access to outpatient.
Right.
Then we have some explanation with our, I guess, commissioner to explain that, or so at least they know what's going on. Based on that.
So is it more around the service interruption as we transition from one location to another, or just access in general? What?
Access in general.
Yeah.
Okay.
Yeah, I don't think it needs to be, it doesn't need to be focused on just the transition into the new buildings. It needs to be, to the extent that our demand is continuing to grow, we need to be able to illustrate that in hard data terms. And days, for next appointment is one of those metrics, and I think it's useful. It has to be taken in context with a lot of other things, because in some cases, and Zelia will tell you this, we've seen PEC emergency demand go down, not because there's fewer people that need service, but because we've been more successful in getting those people into a clinic environment and coming in for appointments. Well, that's a huge benefit. It's a huge win for us. So you can't take it as one, idea and say this defines the entire process. But I think to the extent that we can continue to, isolate metrics that do show the true demand as well as true access moving forward, it goes well beyond the transitional phase of moving into the new buildings.
Okay.
This also helps us with staffing, right? If we don't have the provider to see the patient, it may increase, but that doesn't mean that we should cut from outside looking and said, oh, you can still operate without those providers. Why don't you take them off your budget?
End up in the ED.
Yeah, exactly. It costs us more. Yeah.
Good
Okay.
feedback. So you got the summary page, but a couple of highlights on the income statement just for a little bit deeper dive. I've talked about salaries and wages all year and how contract labor has been down. We continue to see, just a very slight difference when you combine those two together for the month of April. But then year to date, you're seeing the net be positive. So we're about 6.5 million overall. When you combine those labor categories, we're favorable. Budget in the month of April for benefits, you can see we have a little bit of an interesting difference in benefits. It's mostly related to a pension actuary. Every year, the actuary is going to value that pension, and we had a little catch up to do over the last part of the year here. And then supplies is a little bit over budget, but when you do adjust for our volume, we are very much on target from a flex standpoint. And then I would point out that ad valorem did come in about $1 million under budget, but we are experiencing a time of year where we are seeing just levy adjustments. That's a normal process. We have those taxpayers that would appeal or protest, and then we get an adjustment. So that's kind of a normal course of business. And also, we had a TIF refund in that ad valorem category as well that helped offset those levy adjustments.
TIF refund? How do we get a TIF refund?
City of Benbrook. That's the extent of what I know about it. So
Interesting, no. The only way we'd get a TIF refund is if you have a project cost that doesn't occur, and so the dollars that were allocated from the county to pay for that project cost are no longer necessary. In that case, you have to, you pay back each participating entity, of which JPS is one of them.
Right.
So it's unusual. We don't see that very often.
Not very often, but we'll thank the city of Benbrook for that one. And then investment income, I talked about the bond situation a little bit. And then we did cover the days cash on hand in the summary. I would point out that our claim division continues to trend right on budget, very favorable operationally for the year. And then answer any questions and take a motion on the approval.
Okay, additional questions for Rory, either on the income statement or the balance sheet, any of the financial presentation? If not, we'll entertain a motion. Motion from DT, second from Ralph. Any question or discussion? All in favor say aye. Aye. All opposed, same sign. That motion carries. Thank you, Rory. Let's move into approval of pulse oximetry sensor supply agreement.
So pulse oximetry, it's one of those things that almost every patient that comes in here is going to be utilizing. If you're not familiar with that, we are using that technology to check that saturation level. And so it is a bit of a contract that has large dollars attached to it, but it's also through our Vizient GPO, which ensures we're getting the best price for that pulse oximetry technology. So you can see the spend there is over 5 years, 3 years plus 2 one-year renewal options is about a little over $7 million for the entire contract. No, this would be patients here in the facility, not remote monitoring.
Well, this is a budget item. Any questions for Rory on the pulse oximetry supply agreement? If not, we need a motion. Motion from DT, second from Dr. Davis. I'm going to get all these names straight. Any question or discussion? All in favor say aye. Aye. All opposed, same sign. That motion carries. Righty. Rory?
Okay, items C and D we'll kind of discuss together, but maybe take a separate motion if needed on each item. But there are certain disposables and supplies that we use in arthroscopic surgery. So that is a very useful technology for allowing kind of benefit to the patient for less invasive surgery. And so we have 2 vendors here that we are taking to the board for approval for spend, both Arthrex and Smith & Nephew. Arthrex is $2.4 million over a 5-year period, and then Smith & Nephew is $1.7 million. We would request your approval on those 2.
All right. Any questions for Rory? If not, we need a motion. Dr. Fowler? Second?
Second.
All right. Dustin, any question or discussion? Pardon? Can we do them both? Is your motion okay to include both? All right, perfect. Dr. Fowler. Dustin, is it okay with you?
Second, yes.
All right, so we have a motion and a second on both those items. Any question or discussion? All in favor say aye. Aye. All opposed, same sign. That motion carries. Thank you, Rory.
Yes, sir. Lastly, item E is Medline. Medline is our prime distributor. If you're not familiar with that terminology, they sit between the manufacturer and JPS. And so we use Medline as that prime distributor. This was an RFP that was conducted. There were 3 years of spend approved, and I think the trend now is to kind of go to the board and get those additional optional years approved. This was not done back at this time, so we're just coming back asking for that additional 2 years of spend. I would note this is a kind of an area we're looking very, very strongly at from a supply chain, cost and efficiency. And so we do have a 90-day out on this particular contract in case we need to move and move a different direction in the future. So.
All right, any questions for Rory? And we need a motion for the medical supplies between Medline Industries. Motion from Ralph. Second from Dr. Fowler. Any question or discussion? All in favor say aye. Do you have a question, DT?
Not for two vision.
Does that satisfy your question?
Yes.
All right, so all in favor of the motion say aye.
Aye.
All opposed, same sign. That motion carries. Thank you very much, Rory, and does that do it for you? It does.
It does, yes.
Jill, you'll come up and talk about the pricing agreement between Steris Corporation and Tarrant County Hospital District.
Yes, I'm looking for your approval of a pricing agreement with Steris to purchase 13 endo dry cabinets for our endoscopy and ORs. The price is, for the purchase is almost $592,000, and it is based off our Vizient contract.
All right, any questions for Jill?
Any supply, basic requirement, supply later on also as well?
Yes, it has supplies that are associated with that as well. It's the accessories that are with the cabinets, but then we also have supplies that are part of our normal operations as well.
Do we have to go to non-bidding next time with this equipment, or?
What do you mean, non-bidding?
I mean, exemption from bidding for the supply, because certain equipment requires certain things that.
I'm not sure if we have or not. Obviously, we have to buy the supplies that go with the equipment that we decide to purchase.
Any other questions for Jill? Not, we need a motion. Dr. Davis, have a second. Ralph, any question or discussion? All in favor say aye.
Aye.
All opposed, same sign. That motion carries. Mr. Showalter, exemption to bid, master product license and services agreement. Thank you, Jill.
Good morning.
Good morning, sir.
I've got a handful of contracts that I'm bringing forward. First one is with Welch Allen. It's $750,000 in capital we've got budgeted for, and then $50K on a yearly basis for license. Welch Allen provides our vital signs monitoring capabilities. They're not integrated with Epic at this point, so this license accounts for 359 devices to be integrated across inpatient and inpatient behavioral health. And this also includes another 115 out of that 359 to be brought to a level where they can even be modified for the connection, so that ultimately we'll have 360 close integrated with Epic. It's a safety issue because we're doing it manually now.
This is a current provider,
Yes, sir.
and you've got 2 one-year renewal options on this one, basically?
Yes, sir.
Okay. Any questions, Bill, on this one? It is item G. Did we skip G?
Did you skip H?
I have us on the Mercury Healthcare WebMD Ignite item, which is item G. Is that what?
I'm ready to go with that, yes.
All right, let's,
My next one.
what was one you just now presented?
Welch Allen,
So which item is that?
That's item I.
So, all right, so we just got,
Got another one.
okay. Bill, if you don't keep me straight, I will just fail miserably at this job.
so the next, I want to set a stage for the next 2 contracts.
All right, good.
Okay, so.
Did we approve I?
Not yet.
All right, then we need to have a motion to approve item I.
Motion to approve item I
Motion
with
from
the exemption to
DT,
bid.
second from Ralph. Any question or discussion? All in favor, say aye. All opposed, same sign. That was DT and Ralph.
With the exemption to bid.
Exception to bid included. Okay, now are we on G?
Okay, let's go to Mercury Health.
All right.
But before I go into Mercury Health and this contract and the next one, I want to just kind of paint the context. Epic is our process engine. There's an awful lot of content that we have to buy and maintain within the system to make it work efficiently. This content is basically focused on educational materials for all environments of care. This is the patient's facing information. You may have known it as HealthWise. HealthWise was purchased by Mercury, which was then purchased by WebMD over the last several years. So there's a lot of shifting going on. But this is our AVS, the discharge documents, the video content for patients, the video content that we put in MyChart. Again, just content from an organizational perspective. Any questions?
Questions? Okay, we need a motion to approve. Motion from Dr. Davis. Ralph, second. Any questions? I think Dr. Fowler actually wasn't it. Sorry about that. And a second from Ralph. Any questions or discussion? All in favor say aye. Aye. All opposed, same sign. The motion carries. All righty.
Then the next contract is with Walter Coolers. It's $123,000, $124,000.
This is item H, right?
Over year of 1 through 3. This is Lippincott. Walter Coolers was bought by Lippincott, but Lippincott happens to provide our evidence-based practice content that's put in within the system and all the reference links. This is a regulatory issue to make sure that we have the content available to nursing staff. It's a procedural level documentation, work instructions, if you will. Again, this is more content that we purchase.
This item needs to include the motion with this, the exemption to bid included in it. Do we have a motion?
So moved.
Motion from Ralph, second. Second from Dr. Davis, or is that Dr. Fowler who said, Dr., you guys, I can't hear very well. Between hearing it and seeing it, it's a challenge. So we have a motion and a second. Is there any questions or discussion? All in favor say aye. And that motion carries. Thank you so much. And that takes us to item J, correct, on the Cisco?
Yes, sir. So it wouldn't be a finance committee if I wasn't coming to the group asking for cash so that we can continue our refresh of the hardware for the network. We're on that trail and we're keep marching down it. This is another $655,000.
All right, any questions for Bill on the busy contract? Not, we need a motion. Motion from Ralph.
Second.
Second from DT. Was that DT?
Yes, sir.
All right. Any question or discussion? All in favor say aye. Aye. And that motion carries. Thank you very much, Bill. We appreciate it. If, do we have anything for executive session? So Ralph, you have something?
See if I could talk to you and Dr. Duncan.
Perfect. We can do that. All righty. Then that concludes our agenda for today. Thank you very much, folks. We will, that's it for today. You got to hang around next time, right? All right. Thank you all for being here. We're adjourned.